Great. So hi, good afternoon, everyone. My name's Sophie Clarke, and thanks very much for coming today. And as you saw the title, there might have been a bit of eye rolling about another paper to do with PCOS. But actually, the reason I thought it would be useful to talk about this today is just building on the back of Maria's Journal Club last week, where we discussed the importance of getting the diagnosis right. And really, hopefully today we'll flesh out some ideas about why it's so crucial in young women presenting with oligomenorrhea to get the diagnosis correct when we can. So the paper I'm going to be presenting today is a large population-based cohort study published earlier this month in JCNM for a group in Cardiff who have expertise in epidemiological studies. And it looked at women with PCOS and the risk of major cardiovascular events. So as I mentioned, you might think, gosh, don't we know about this already? Well, actually, there have been several large population-based studies which have failed to identify a difference between patients with PCOS and controls. But often the sample size, despite being in the thousands, has been too small to identify any difference and has not been adjusted for confounders such as BMI. There is, as you might expect in a young population of women with reproductive pathologies, essentially a low crude incidence of cardiovascular events. And so therefore, an adequately powered study needs to have large numbers in it. Interestingly, this paper was originally published in JCNM, which tried to account for these differences, which did demonstrate in postmenopausal women who had had PCOS an increased risk of cardiovascular events. But unfortunately, the paper was withdrawn as they were unable to reproduce the results. So really, to date, there's been no really good evidence to look at cardiovascular outcomes in this cohort of women. And as we learned and remembered last week, PCOS is a really important diagnosis in women presenting with oligomenorrhea, and is probably the most common cause of it in women of reproductive age. So this is a bit of a reminder for those of you who were here last week and for myself and for everyone else as well. The arrows you need to take with a little bit of a pinch of salt, because as we can all understand and appreciate, it's very difficult to understand where the pathology with PCOS arises. But we know that women with PCOS have hyperandrogenism driven both from increased adrenal production as well as increased ovarian fecal production. We know that hyperandrogenism itself is associated with altered adipocytokines such as leptin. So studies have shown that women with PCOS, regardless of whether they're lean or not, have increased leptin compared to healthy controls. We know that women with PCOS, again, regardless of whether they have a high BMI or not, are hyperinsulinemic and have both an increased basal insulin as well as stimulated insulin. Again, this is despite having a normal BMI often in cases. And we know that hyperinsulinemia in and of itself is associated with other metabolic consequences, such as increased triglyceride and cholesterol production. Now, as I said, these arrows, much work is ongoing really with regards to the nature and the multidirectionality of these relationships. But what we know is that women with PCOS certainly are at risk of metabolic consequences. And not only are there metabolic consequences, but there's also evidence that there are vascular consequences in this cohort of women. So there's evidence that suggests that women with PCOS in small studies have endothelial dysfunction with reduced flow-mediated dilatation. Women with PCOS have increased coronary calcification compared to age-matched controls, and evidence of increased arterial stiffness. So not only do they have metabolic reasons why they may have increased cardiovascular events, but they also have evidence of vascular dysfunction. And also, if we think about anthropometric data, again, as we reminded ourselves of last week, women with PCOS are more than twice as likely to have central adiposity regardless of BMI. And again, we know that central adiposity really is a crude marker of visceral adiposity often as well, and is associated with an increased risk of cardiovascular events. So what this group are trying to establish is, despite all these risk factors that we know about, does this correlate to an increased risk of cardiovascular events in women with PCOS? So to try and understand and properly approach this question, they undertook a retrospective cohort study using primarily primary care data gathered in the Clinical Practice Research Data Link Aurum database, which gathers data from England from 883 general practices. And it's been shown that this database reflects the whole of the country, both on deprivation, age and sex distribution, although clearly in this instance we were focusing on women. And they limited the data retrieved from this to women who had linked data with hospital episode and ONS mortality data as well. So what they were wanting to understand is gathering the patients who had outcomes from both hospital stays as well as primary care data. The primary outcome was the time to a major adverse cardiovascular event, so heart attack, angina or stroke. And the secondary outcomes were individual major adverse cardiovascular endpoints, with the outcomes being identified between 1998 and 2019, so over an 11-year period. And this clearly, as we've talked about, power is really important to make sure the study is able to identify what it's looking and setting out to do. So a power calculation was determined looking to detect a difference in incidence in cases versus controls. They anticipated that around 0.3% of controls would progress to the endpoint. And using a meta-analysis published, I think about 5 years ago, based on 18 studies, they thought there'd be an OR of 1.3 for coronary heart disease in PCOS versus controls. And based on this, they determined they'd need a sample size close to 40,000 for both women with PCOS and non-exposed controls, so women without PCOS. Baseline covariates were compared using just t-tests and chi-squared tests for categorical baseline covariates, and they used a Cox proportional hazards model, which we'll come on to look at time to endpoint. And they adjusted this model for various parameters, which again we'll come on to look at. They looked and adjusted for age, BMI, the baseline morbidity, which is using something called the Charlson Index, blood pressure and relative deprivation, which have all been shown to be impacting on coronary heart disease and cardiovascular events. So here, this diagram, we can see actually what the patient flow was like, but essentially patients who were excluded were those who were less than 18, and those who were not matched to non-PCOS controls, who were not eligible for the linkage scheme, and who had an index date, i.e. their diagnosis of PCOS or the cardiovascular event was outside the inclusion date. So they ended up with a really large sample size of 174,660 women with PCOS who were matched by age and BMI to a control. And Julie asked a useful question about what determines whether a patient has secondary data linked. And I don't know actually, Julie, if that's a patient opt-in or not. I'm not sure about that. So as I said, patients were matched to non-PCOS controls, and they were matched by age and BMI category and primary care practice, which was essentially a surrogate marker for deprivation index. And they were followed up until the earliest of the following. So either the end of the follow-up, the end of the hospital data, or death date. So the median follow-up was just over 3 years, and the median age was 29 years for both PCOS patients and controls, or patients with PCOS and controls. So this is a young cohort of women with PCOS. This is a table of the baseline variables. I'm just going to draw your attention to those that were different between the two groups. So we've got PCOS here and controls here. So BMI categories, smoking status, alcohol status, Charlson Index, which if you remember is an index of morbidity, blood pressure, and prior comorbidities were different between the two groups. And specifically, there was a greater proportion of patients who were extremely obese in the PCOS cohort. There was a greater proportion of patients who were ex-smokers. A greater proportion of patients with PCOS drank alcohol currently. So as we can see here, this is summarized here. So the groups were not the same, which I guess is important to remember when we're looking at the data. If we come on to look at the results, we can see that out of our large cohort, there were 804 incident events in women with PCOS versus 522 events in controls, with an approximately third increased risk in women with PCOS. And that increased risk was remained when the model was adjusted for age, BMI, deprivation status, and comorbidities. If we look at myocardial infarction, if we look at this graph, this is missing the axis here, which says survival, and we've got time along here. The black line represents women with PCOS, and the slightly more tricky line to see represents controls. And as I said, this is called survival, but perhaps one way to think about it is how many people do not have a myocardial infarction. So at time 0, 100% have no myocardial infarction. And as time progresses, we can see that starts to drop off. So 221 women with PCOS had a first instant MI compared to 129 controls. And when this was adjusted for the significant covariates of age, smoking, previous type 2 diabetes, and deprivation, that remained with an odds ratio of 1.38. And it's significant, as we can see, because it's greater than 1. And again, the 95% confidence interval is greater than 1. If we limit our data to just secondary care data, sorry, I can't see the bottom of my slide now, but essentially that risk remained. So it was approximately a 50% increase. If we come on to look at angina, again, we can see that women with PCOS, there were 319 incidents of angina versus 161 controls, and that remained when adjusted. At this point, other significant covariates included systolic blood pressure and BMI, as well as smoking, type 2 diabetes, age, and deprivation. We come on to look at stroke, again, just reminding ourselves that here in the black line, we've got women with PCOS, and the grey line represents women without PCOS. There was no significant difference, essentially, when looking at the primary care data between the two groups. If we limited it to just secondary care data, then there was a hazards ratio of 1.26, so that was significant. But the hazards model wasn't undertaken because it didn't essentially meet the criteria needed to do the model. And then if we come on to look at cardiovascular mortality, again, there was no significant increase in mortality between the two groups. The group then looked at the hazards ratio derived from the models, looking at just the composite endpoint, which essentially is a composite outcome that looks at all of them put together. And they determined that weight increase, prior type 2 diabetes, and deprivation index all significantly adjusted the hazards ratios. And interestingly, a 1 kilogram weight gain appeared to increase the risk by 1%. Although, as you might anticipate, type 2 diabetes had a greater impact on the hazards ratio. So in terms of the discussion, as I said, this is quite a short study that we're talking about today, but I think the findings are really important for us as endocrinologists and diabetologists meeting these women frequently in clinic. So although there are small numbers, we can see that women with PCOS are at increased risk of cardiovascular events. The numbers are small. We have sample sizes of 140,000 nearly, and we're talking about numbers in the hundreds. But this is a young cohort of women, median age of 29, and clearly having your first heart attack at that age is a really significant event. So not only are there increased cardiovascular events in women with PCOS, but there's also increased specifically heart attacks, angina, and episodes of revascularization. Whilst mortality isn't increased, morbidity is. And again, given that these are young patients, they are going to be living lifelong with these complications. And therefore, I think it's really important that we remind ourselves of this. There's a relatively short follow-up. And as I've talked about, there is a low crude index. So i.e. there's a very small numbers that we're talking about. But nevertheless, the data is there that these women are at increased risk. I thought it'd just be worth reminding ourselves of NICE guidelines with regards to management of cardiovascular outcomes in women with PCOS. And one of the recommendations that may well be better managed in primary care, but I think certainly as secondary care clinicians or tertiary care clinicians, we should be thinking about, is thinking about glycemic control in this cohort. So as Maria alluded to last week, we know that in women with PCOS, whether they're lean or not, have both increased basal insulin, but also increased stimulated insulin. And so therefore, even if they're lean, they're at increased risk of insulin resistance. And so the NICE guidelines currently recommend that all women with a diagnosis of PCOS should have a 2-hour oral glucose tolerance test if they have a BMI of greater than or equal to 25, or if their BMI is less than 25, but they're over 40 or have a background of gestational diabetes, or if they're essentially an ethnicity other than Caucasian and they have PCOS, these women should be getting OGTTs. Now, this is probably something that would be better managed in the primary care setting, but I'm not sure actually in secondary care whether I'm particularly aware of asking women if they've had an OGTT, if they know what the results of that are. And indeed, if they do have evidence of impaired glucose tolerance or fasting glucose, then they should be having repeats oral glucose tolerance tests annually. There's evidence that suggests that HbA1c's in these women, particularly given that it's a postprandial hypoglycemia that seems to be affected, is not helpful. And therefore, I think we do need to be thinking a little bit about talking to women about being aware of their oral glucose tolerance test results, what the impact of that is, and indeed what the consequences are going forwards. So as we've talked about, a 1 kilogram weight gain is associated with a 1% increase in risk. We're talking about small risks, small numbers. But given that these women have got a life ahead of them of living with this condition, certainly we want to make sure they're armed with all the best information possible. So I guess our questions for us as a group to be thinking about is, do we think women are getting routine assessment of glycemic control? Are we counselling women appropriately regarding the long-term health implications of a PCOS diagnosis? And perhaps do we need to be thinking beyond the fertility paradigm when assessing these patients? Obviously, it's fertility that often prompts the referral to our services or oligomenorrhea. And given that obviously we have limited time with patients and this may not be their prime concern, you obviously don't want to flood them with information. But I certainly think it's something that perhaps at a follow-up or something we do need to be thinking about, counselling women about, and indeed giving them advice about next steps. And I guess, again, this is something where there's scope for a lot more research, because for this cohort of patients, we say you need to manage your lifestyle and try to avoid weight gain where possible, or indeed lose weight to improve oligomenorrhea. But actually, what is the best lifestyle management? So I still think the jury's out with regards to that. So I'd like to thank you very much for your time, and obviously you're happy to have any questions, be happy to take them. Thank you.
Yeah, very good. It's all about the control group, really, isn't it?
I think that's the strength of this study. So these were age-matched, BMI-matched women without PCOS. So I think that's where this study is really strengthened.
Yes. The smoking difference, though, okay, why is that? There's a difference in the prevalence of smoking.
So I guess if we come to look at that baseline table. Yeah. So there's a difference, but actually we're talking about 13% versus nearly 12%. So 23,000 versus 20,000. Okay. I'm not sure how that is. And actually smoking status, where it was found to be significant, was incorporated into the adjusted Cox proportional hazards models for where it was found to be significant. So it was adjusted for. I think Shivani's got a question.
Yes, sorry, yeah.
Hi, Sophie. Thank you.
Hi.
You presented that beautifully. Yeah, I think my question was about the control group too, because although it's matched, they're significantly different. But I guess I'm just looking now with a closer eye. These are just statistically significant because they're such large numbers, aren't they? Because actually, I was looking at the BMI, because wondering why that was coming out differently, but they're quite similar percentages.
Actually, if you look, the obese is actually larger in the controls versus the PCOS women. But again, it's 16 versus 17%. So I think the only thing that actually was statistically significant was the extremely obese. And again, we're looking at 5,000 versus 8,000 out of a cohort of nearly 140,000. So again, I think that I think that's a concern, but I think It's a numbers thing. And actually they've adjusted for BMI where it's been shown to be significant in the model. Yeah.
Okay, thanks.
I think it's very difficult when they say, and we've controlled for, and then they put it through something that nobody understands, and then they go, therefore it's significant. Do you know what I mean? The so-called proportional models. I mean, I don't know if I trust the statisticians. I mean, it just, it happens a lot.
Yes.
There's a lot of manipulation. You find a significant difference, and then they say, oh, we adjusted for it. Don't worry about that. And that's the problem. I don't know the answer. I'm just telling you, it's very tricky when they do that.
Yeah, I appreciate that. It is difficult, but yeah, it's difficult. I'm not a statistician. I suppose in large cohorts we don't really have any other option as
indeed
in in terms of adjusting for it. And I think this is as closely matched as you can get, really. Yeah.
I think Alex has got his hand up as well.
I was just going to say that was excellent, Sophie. Thank you very much. I guess it makes sense physiologically that patients with PCOS would have increased risk of cardiovascular complications. And I guess this is, as you said, the first study because the risk is so low in this age group. But I guess if you extend it to the lifetime of a patient with PCOS, that's why we should probably be more aggressive in our targeting or searching for any problems with glucose homeostasis early on, because these events are going to happen 20, 30 years down the line. And that's where you'll probably get even better significance, if that makes sense, I think. Yeah,
that's really helpful, Alex. Thank you. I think that's exactly it. These are women who are the median age of 23 who have had a heart attack, potentially.
Yeah.
And as you say, we need aggressive management. I think the difficult thing is, what do we do with this? So fine, we can say to women, you need an OGTT and then you need to be counselled about it. But what do they actually do? I'm not clear that we have appropriate evidence base to suggest various lifestyle measures other than lose weight, which, as we all know, is actually a fairly poor, as a clinician, it would be really nice if we could say, this is the best way to do it, which we're, I guess, a way away from.
I guess most of us would do an HbA1c and maybe a fasting glucose, but we wouldn't do OGTTs, not to overwhelm the system, but maybe we should. I mean, nice guidance is obviously that we should, but are we going to start doing that?
It may be that we need to select the cohort of women for whom an OGTT will be most helpful. So if you've got a young woman with a new diagnosis of PCOS, then I think we probably should be doing an OGTT. And then we can use that to then inform her at the time of diagnosis. I suppose if you've got a woman who's postmenopausal, an HbA1c in that instance would be helpful, in that she may then have additional factors that will raise her HbA1c, so it's not just postprandial, if that makes sense. I don't know what everyone else thinks.
Okay, and Shivani's got a hand up again.
Hi, sorry. So interesting. I mean, just looking at this table again, Sophie, there is quite a significant difference in the number of women with type 2 diabetes. So how do we know that this isn't all driven by early onset type 2 diabetes in the cases? Because they didn't adjust for that, did they?
So some of the models they did, where it was found to be significant. But again, I think that's very interesting, almost in and of itself, that this is a cohort of young women who at the median age of 29, the IQRs 24 to 34, already have a diagnosis of type 2 diabetes. And I almost think that in and of itself is really interesting, isn't it? That actually this cohort of women will have a lifetime of type 2 diabetes and all its consequences to go with that.
But then arguably what we should be doing is just identifying those women that have, I mean, I guess the question is, do you think that there's something in PCOS that is not being driven by the glucose metrics that increases the cardiovascular burden?
So for example, does hyperandrogenism in and of itself increase vascular function or poor vascular function? I don't know. I don't know, but I suppose the only thing that would make me cautious about relying on the type 2 diabetes, for example, is the fact that studies have shown that you can have a normal HbA1c with lean PCOS and yet still have impaired postprandial insulin secretion, essentially, which then would put you at high risk of developing insulin resistance down the line. So I suppose it's that cohort of women that we should be really keen to pick up on. By the time they've got type 2 diabetes, it's almost too late, isn't it? And not too late, forgive me, but do you know what I mean? There's lots we could do then, but I suppose it's a different approach at that stage.
Yeah,
so
I think no, I think you're right. I think Stanley Andrews, that prof that came over, was talking about exactly this, right? So metabolically unhealthy, lean, the metabolically unhealthy but lean phenotype. But yeah, no, I'm not convinced that these findings aren't driven by type 2, because early onset type 2 diabetes is such a huge burden for early onset of cardiovascular disease within 5-10 years of diagnosis.
I guess does it matter, I guess, is the other question, whether it's PCOS driven type 2 diabetes related, as it were, or pure diabetes.
Which came first? Which came first?
I think it matters, as the premise of the paper is that it's PCOS driving it.
Yeah.
I think clinically you're right.
Yeah.
I mean, what we're interested in is doing a cardiovascular risk assessment that's going to include glucose metrics. But yeah, for the premise of the paper, I think it matters. But you did say, didn't you, that in one of the models they adjusted out prior type 2 diabetes?
Yeah, so both the myocardial infarction model and the angina model, they adjusted for type 2 diabetes. But again, as Prof says, I'm not sure how you adjust, and I don't know that.
Which came first? And then the other thing is, I mean, it's interesting, isn't it? Why is the gene for PCO, or the genes, the many genes for PCO, so prevalent in a condition that causes infertility? It's odd, isn't it? You'd think he'd be selected out.
But I suppose it's only, that's a bit, everyone else very free to chip in, but I suppose it's only recently with lifestyle changes that things such as increased weight has taken on. The phenotype of us now is quite different. Yeah.
What I'm getting at is whatever drives type 2 diabetes being so prevalent, which is, maybe thrifty genes or whatever, maybe it's the same overlap. Whatever it is. So in other words, in the distant past, you survived if you were a bit obese and you were at risk of type 2 diabetes, but that didn't matter. You died before you got type 2 diabetes because everyone died of sepsis. And maybe the same group of genes or some of those overlap will give you a PCO-like phenotype. I'm just thinking, do you not think there's a bit of an overlap between they both cause each other, is what I'm trying to say.
Almost certainly. Yeah. But I mean, don't forget though, when we look at SNPs or just polygenic signals that increase risk, what we're not very good at capturing are the ones that also decrease risk. So when you look at sort of segregation of two disease phenotypes and shared loci or variants, there's a lot of missing heritability there that we often don't capture. But yes, there's something environment is unmasking genetic predisposition in all of these things.
Yeah.
Sophie, can I ask a question? Would you change your treatment of PCOS patients as a result of this? I mean, would you use more metformin at an earlier stage rather than an oral contraceptive pill to regularize cycles, or would you do that based on an OGT?
I think that's a really interesting question. I'm personally not convinced that the data is there for metformin for increasing menstrual cyclicity. So I think if I was to start metformin, I'd need to be really clear with the patient about why I was doing that, and counsel them that I don't necessarily think it's going to improve their cycles, but may improve their metabolic consequences. I think where this changes my practice is in terms of that, obviously you can't overburden a system, but those young women with a new diagnosis of PCOS, I think I would want to get an OGTT on them for them, and then explain to them why I'm doing that and what that means from going forwards. And thinking about times of life where weight gain happens often, so 30s, around the time of the menopause, trying to counsel them about the impact of that. I don't think there's an evidence based on this certainly to use metformin sooner. personally, but happy to be corrected or impacted, happy to be disagreed with. Thank you.
Very interesting. Any other thoughts? It's a good point, actually, about using, I mean, metformin, of course, is very popular amongst the PCO patients. You go to any PCO website, they're all saying, go and get your doctor to give you some metformin.
Yeah, I guess, yeah.
That's patient driven, that's not science, that's patient driven.
Yes, yeah, and I guess it depends what stage of their diagnosis they're at, what's triggered the diagnosis, and often they're, you know, it's as clinicians we have very little to offer. I think that's quite frustrating clinically on both sides of the interaction, isn't it?
Yes, absolutely.
Yeah.
Quite a big fan of metformin for menstrual cyclicity, and I think I've seen many patients who've improved, even lean ones. One that I dealt with this morning, actually, I went put on metformin. The reason being that if you improve the insulin sensitivity, then it's actually the ovarian fecal cells that respond to the high insulin to drive the high androgens. So if you decrease their insulin by improving their sensitivity, then they get less androgen, which then causes less disruption of their menstrual cycles. So I'm quite a big fan, and based on this paper, I would probably have even more evidence to do it.
Yes, I think what this paper does, Alex, is permits you to do what you've been doing already, because up to now, it's slightly non-evidence based, isn't it?
Well, the evidence base for
metformin
PCOS and cardiovascular complications.
Well, the risk, yeah. I mean, if the risk is higher, then there may be some benefit, but
sometimes, as Shivani says, we know that PCOS causes metabolic complications, and so physiologically it makes sense. Here it's been difficult to find because all the patients are so young, so the events are very low, so it needs a massive samples. But if you actually probably looked at PCOS patients over the course of their whole lifetime, followed them up for 50 years, I'm sure you'd find easy significance.
Yeah, it's a really interesting point.